value-based care and that doctors have to do much more with less. Again, I'm not assuming everybody knows. What is value-based care?
Value-based care is instead of getting paid for a procedure or services rendered to a patient, it's based on outcomes, patient outcomes.
Oh, Lord, that must make
so it's a
happy.
very, very different method of delivering health care than we had in the United States up till recently. We would treat a patient's visit, everything was episodic. When a patient came in, you treated them for the symptoms and the cause for that visit.
Right.
Today, it's no longer. It's longitudinal care.
Good Lord.
All caregivers for that patient have to form a community around that patient, and the patient has to be engaged in their care. Otherwise, we're never going to have positive patient outcomes.
Okay, so you form a community, which in certain ways is not a bad thing. It's nice when the primary care doctor is talking to the drug counseling social worker, who's talking to a dietitian, who's talking to whatever, and they pull it together. That's very nice. But how do the mobile tools pull this all together?
Well, technology up till now has been all designed around episodic treatment. Everybody has EMRs that are in silos.
All right, and EMRs is the electronic medical records, just to make sure everybody, because I hear EMRs, EHRs, which is the electronic health records, which is, as far as I know, the same thing, so you never know who's telling which one. So, okay. EMRs, electronic medical records.
Are geared around episodic treatment. They are not geared to share information. Besides all of the talk about interoperability and we need to get there, they haven't yet gotten there. So DrFirst does have tools which will share clinical information regardless of the EMR that you're on, EHR that you're on. It also provides tools for secure communication with other clinicians and patients.
Oh, okay. So when we say other clinicians, when I worked with one group, they had what was, and this is a decade ago, where people were starting to use the USB. And so they set up a system, and just within their senior centers, and the residents could get a USB portal and take it to whoever their doctor was, as long, and still 10 years ago or 15 years ago, to have a doctor who had this thing where you could just put your USB portal in, and there it would come up. Hi, Mrs. McGillicuddy is on all these medicines, and here's her allergies and so forth. So whether she was taking it from her primary to her urologist to whatever, that's nice if Mrs. McGillicuddy's bringing you the port, but when you don't have that, you're still not connected. It gets so screwy.
Right. This is a direct communication that goes from one practice to another, one doctor to another, a PT worker to a physician, and it's wanted also to the patient.
Okay. And so we'll answer the obvious question. How does having this complete patient medication history contribute to the early identification?
That's one of my favorite topics.
Okay.
Medication history, again, because we did episodic treatment, was kept in your EMR, but you didn't know what meds the patient was getting from an ambulatory center across the street.
Right.
You were relying on the patient to give you that information when they came in. Patients are the most unreliable source for their own. I could tell you we used to get, I don't know, I take that little blue pill for my blood pressure.
Uh-huh.
Right. Our medication history that we provide is a comprehensive medication history from short scripts feed, payers, pharmacies that we've partnered with, past medications that the patient has given you. So what happens is your medication feed in your EMRs, because we do partner with the EMRs for this, is far more complete.
Far more complete, yeah.
Right, most medication errors occur from not having a good medication history.
Oh, yeah. I mean, I can imagine. And, you know, I just mentioned the senior population. I've done a lot of writing about caregiving, so it's really nice if the patient can remember all of this, which, as you just mentioned, they can't usually, and especially as we get older and we're on more medicines, or if we're in early onset Alzheimer's, and we're lucky if we remember a bunch of other things, let alone our medications. But the caregiver, you know, your daughter, your cousin who is nearby and doesn't mind watching over you. And I'm talking about family caregivers, not just other professionals. They don't have the information and they don't know where to find it. If it's not in a total system where you can just punch in, as I said, Mrs. McGillicuddy's name and it comes up, then we're really talking trouble.
Yes, I recognized this deficit in 2008 when I was still a CIO, and I actually went out. That's how I originally found DrFirst. I partnered with them to receive that medication history at the time of admission for our patients.
Yeah, I mean, I worked with a client, and he does billing issues related to Alzheimer's specifically. And if the patient kept coming back in and and you treated him properly and got him out of the ER, but you didn't get Mr. Stevenson's full history because he forgot certain things and he wasn't carrying his USB port or whatever, then he came back in and back in and back in. And not only doesn't this help Mr. Stevenson, but it actually ruins your hospital rating because you can't keep people safe and secure. So
and get reimbursed for that readmission if it's under 30 days.
Right. So if you keep failing, Mr. Stevenson, if you God forbid you don't care so much about Mr. Stevenson as a hospital, but you want to keep your rating good, at the very least you've got a good reason that way to make sure he stays well.
You also have a good reason to ensure that the patient after discharge is adhering to what the medications that they should be taking.
Oh, yes.
We also provide letting you know whether the medications have been administered by the drugstore, picked up at the drugstore.
Okay. So that helps to some degree. And there's still the issue of when they get home, because I did an article a few years ago for Johns Hopkins where they had discovered, and again, it's a few years ago, but it was something about that the patients were saying, oh, yes, I understand the instructions, don't worry, it's okay, and they'd get it home and not take it properly. So if they're, whether they're gobbling their opioids or they're doing it cockeyed, and so that's not helping them, all sorts of things. It's just very complex.
That's why our tool to communicate securely with the patient after discharge is so important, because that's when the patient will recognize that they really didn't understand the instructions.
Okay, so we gather it all together. Can their family get access to this if John Smith can't remember to tell you that he's done everything, but his daughter-in-law is stopping by or calling him, or whatever, can the daughter-in-law do the information input for them?
Yes, anybody that's authorized by the patient.
Okay. Well, that's very good.
Also, another area that I think we excel in is many patients do not pick up their medications because they cannot afford to.
Yeah, yes.
And you're using our electronic prescribing application. When you prescribe a med, it lets you know the patient's copay for that med with their insurance company. It'll let you know if it's on the formulary for their payer and if there are coupons available to offset the cost of the copay.
Oh, that's great. That's great, because it's been hard enough under all the healthcare systems we've had, and even in all due respect to Obamacare, the Part D drug plan, I had to interview literally face-to-face Bush 43 at one point. The Part D was just about to come into effect, and they had to admit the Republicans had set this up, and there's a huge reimbursement gap for seniors. You know, I don't remember the exact numbers, but if your prescriptions were up to, let's say, $2,500, you got the 80% reimbursement, and then if it went to $4,000 something, they paid for the whole thing. But there's that donut hole, they call it, in the middle, where tough noogies, you know, if you're
Exactly. And
yeah,
also,
and we don't know what's going to happen now.
They'll tell you when you do a study that the primary reason meds aren't picked up is due to the cost of the copay.
Yeah, and
so we're
I'm
trying
terrified
to close that medication loop. Safe prescribing,
I'm terrified it's about to get worse. We don't know. When I see my insurance info, because I'm self-employed, and we had a show on being self-employed, because if you encourage, you have a nurse or a teacher, someone who spent 20 years, signed off, got their pension, they're safe as far as that goes, and they want to have their own business. It's always been their dream. I met one lady at an Epilepsy Foundation conference where she'd been, I think, a teacher and gotten her pension and opened her dream flower shop, and the next thing she knows, she's in a mild car accident, and she's having tons of seizures. And now you're self-employed. How are you supposed to pay for any medicine, let alone all these other things? I mean, it's very scary.
So these are the things that what DrFirst has done is try to look at the gaps in our current technologies and create solutions to fit those gaps.
Okay. Well, we are actually headed to the 2-minute countdown, so I want to tell our listeners that there is a website. It's called beforeitstoolate.maryland.gov, and it will give you a lot of information on what the state, at least, is doing, and if you're concerned, and I hope you are concerned, especially if you're among our health professionals listening, that whether you look at DrFirst, whether you try and find any solution that will work within your state for the patients, because remember, these are not terrible people who just want to rob homes. You know, these are good, solid citizens. They said in Maryland, this has been a problem in the inner city for years. Now that it's affecting the suburban communities, people want to do something about it. And that means I've got to thank Linda Fisher, the Vice President of Product Strategy for DrFirst, based here in Rockville, Maryland. I can't tell you what fun this has been. Fun but sad at the same time, right, Linda?
Same thing. I do want to mention one thing very quickly. There is a bill before both Senate and Congress to make e-prescribing of controlled substances mandatory on a federal level for all Medicare, Medicaid patients, and that bill is going to pass.
Okay, well, thank God. I thank Linda Fisher again. This is